Well, I'm going to preface my introduction just by saying that these conferences, I think, are a very important part of our endocrine training program because they allow our fellows and to some extent junior faculty to have access to the research activities that are going on within the department on the part of the faculty, both in endocrinology and diabetes. And this is very important work. It's also part of our obligation to the accrediting authorities for the fellowship. So it's great to have an audience and great to have the participation both of our faculty and the fellows within this program. And it gives me a particular pleasure to introduce Ben Nwosu today because he has been a stalwart supporter of these efforts and really a paragon of clinical research by a physician scientist. Ben went to medical school in Nigeria, came to the United States, did his training initially at Howard University, and then subsequently became a fellow at NIH, where I think the research bug infected him quite successfully. He has been at UMass for quite some time. He's risen through the ranks to become professor of pediatric endocrinology. And from my point of view, has perhaps authored about a dozen of these faculty research presentations over the decades. And it's my delight to have him here again. He's published over 40 articles in peer-reviewed journals. He's first or senior author on almost all of them. I present him as a role model and look forward to what he has to tell us with Krish and Sandy. So with that, I will turn it over to you, Ben.
Thank you so much, John. I really appreciate this opportunity to present what's going on in the pediatric division. Today, I'll be joined by two presenters, Krish Khatri, who is one of our adult endocrine fellows, and then Parajuli, who is a foreign medical graduate who is preparing for residency, but has really done a lot of work, both the level of randomized control trial and the retrospective studies. So I will start out with this question, which I try to do from time to time. So in the early stages of adult type 1 and type 2 diabetes, this lipidemia is most likely related to which of the following. So the options are sex, age, BMI, C-peptide, hemoglobin A1C, and ethnicity. So we'll probably answer this question at the end of our presentation. I have nothing to disclose. We have a grant from NIH. And by way of background, we're going to be discussing both type 1 and type 2 diabetes. So let me just go over this quickly. Type 1 diabetes is believed to be a syndrome of persistent hyperglycemia, usually due to an autoimmune destruction of the beta cells of the pancreas. And so when we're able to pick up the diabetes-associated autoantibodies in serum, we classify that as type 1A. However, there are cases where type 1 diabetes could also result from fulminant viral infection, as in the case of congenital rubella, which wipes out the beta cells of the pancreas. So we're unable to pick up the autoantibodies. And in this case, we classified this as type 1B. Following the diagnosis of type 1A, in most cases, there is a period of increased exogenous insulin production that lasts from maybe 3 months to 1 year, but they have also picked up evidence of increased insulin microsecretion in people who've had diabetes for more than 50 years. So this little hump here is called the honeymoon phase. And we're going to talk about this honeymoon phase a lot in our presentation. Type 2 diabetes, on the other hand, is a syndrome of persistent hyperglycemia resulting from two major pathophysiological mechanisms. insulin resistance, which may be present or absent, but more importantly is the increased beta cell apoptosis, such that the body is not able to compensate for both the insulin resistant and the dying beta cells, and then it results in persistent hyperglycemia. You can contrast that to metabolic syndrome, where they do have insulin resistance, but they are able to adequately compensate, and such you have normal glycemia. So the honeymoon phase is characterized by residual beta cell function, production of insulin endogenously and C-peptide, and lower risk of hypoglycemia. And it's also a period where you could introduce new strategies to either lengthen the duration of partial residual beta function or expand the beta cell mass. So usually people ask, why are we doing this presentation? Do we have something to back up what we are going to say? So let's go over a few slides. So in 2017, we started this journey in the area of partial clinical remission. We established the prevalence of partial remission and showed that the peak period of remission is around 6 months following the diagnosis of type 1 diabetes. And boys have robust partial remission compared to girls. We also showed that there are easily obtainable clinical parameters that you could actually use to predict who may go into remission or not. So if you have a child with bicarbonate of less than 15, who is less than 5 years of age and is a girl, and has three or more diabetes-associated antibodies, it is less likely that that child will go into remission. And I want to point at the bottom, people who are involved in this or who were involved in this research. The first two authors were our residents then, and Jasrodia was a foreign medical graduate from India who actually started this rolling. And then we had adults, Mike Thompson and Laura Alonso on the study as well. Now, that same year, we also showed that if a child is requiring total daily dose of insulin of less than 0.3 units per kilogram per day, then that child is in remission, because we compared this insulin requirement to the gold standard clinical definition of remission, which is using the insulin dose adjusted A1C. Now, we also looked at midterm effects of partial remission, and we showed that those who did not experience partial remission had worse lipid profile 5 years after their diagnosis. So by the end of 2018, we had been able to characterize a few things about remission. We had a predictive model. We knew how to monitor for remission. And then we also showed the consequences of lack of remission. Now, we wanted to challenge a prevailing theory then that children who had type 1 diabetes do not experience improvement in lipid profile during puberty. What we saw in our study was that, yes, children who are of normal weight, who do not have diabetes, did experience normal improvement in lipid parameters during the teenage years. And then those who are remitters also did likewise. But those who are overweight and obese and do not have diabetes did not experience this phenomenon. The same also applied to the non-remitters. So we were able to show this and characterize this fully. But there was a gap. We never looked at type 2 diabetes patients. But we then set on to do that in 2020. And we found that when we added type 2 diabetic patients in the picture, those people who did not experience partial remission had LDL levels that looked like those of the type 2 patients when compared to the controls and the people who were able to remit. Now, we know that we did not use fasting lipid parameters for this study, so we also included non-HDL, and the picture was the same. Higher levels in the type 2 diabetics and the non-remitters, and less non-HDL concentrations in the controls and the remitters. So with that, we say, why don't we look at adult patients? Because maybe they do have this same phenomenon that we're seeing, or maybe not. But why study this lipidemia in adults? There's so many reasons, but I just summarized it here. Number one is that atherosclerosis starts in childhood. So what people are seeing in adult patients is actually what starts, in children. And so it's a progression. And 25% of our patients have progressive and persistent dyslipidemia. But more importantly is the fact that CVD is the leading cause of death in adult patients with diabetes. But for me, what I saw that also made us think that this is a project worth doing is that CVD risks are established in type 2 patients, but not so in type 1. And the underlying determinants of lipid phenotype in type 1 are not known. So the recommendations for management of dyslipidemia in adult patients with type 1 are actually derived from adult patients with type 2. So here is our study. I'll hand this over to Sadie now.
Hi, good afternoon, everyone. My name is Sadichchha Parajuli. So talking about our study, we conducted this study to determine and compare early lipid parameters in adults with type 1 diabetes and type 2 diabetes. Next. So the aim of our study was to investigate the impact of partial clinical remission on earliest CVD risks in adult type 1 diabetes. And we did it by comparing lipid phenotypes in study groups. We had 4 study groups in total. Type 1 diabetes group were stratified into remitters and non-remitters. Another group was type 2 diabetes and controls. Also, we focused on factor analysis of lipid parameters, which we'll discuss in subsequent slides. Next. So the study's hypothesis is that primary lipid markers, LDL cholesterol, non-HDL cholesterol, and total cholesterol will significantly be elevated in non-remitters and type 2 diabetes subjects compared to remitters and controls. So this hypothesis, we speculate that would lead to generalized theory for mechanism of atherogenic lipid profile in youth with type 1 diabetes or type 2 diabetes. Next. So we started with IRB approval from UMass Medical School. Next. Coming to subjects and methods, it's a retrospective study. So we reviewed 312 charts and collected 40 subjects in control group, 77 subjects with type 1 diabetes, 86 subjects with type 2 diabetes, and altogether used 203 subjects for final analysis. We recorded age, weight, height, BMI. We documented family history or other medical illness and medications. We extracted labs, including diabetes-associated, diabetes-related autoantibodies and lipids. We also documented the pattern of glycemic control and type of treatment like insulin, metformin. We calculated BMI and partial clinical remission. Next. So partial clinical remission is defined by insulin dose adjusted A1C of less or equal to 9. The equation that we used is IDA1C equals to SBA1C in percentage plus 4 times total daily dose of insulin in units per kg per 24 hours. IDA1C is used as a surrogate marker of the gold standard definition of PCR, which is either a fasting C-peptide level of more than 0.1 or 2 hour post-meal stimulated C-peptide level of 0.2. Next. So these are the assay techniques that were used for serum lipids and diabetes-associated autoantibodies. Next. Inclusion criteria, study subjects were adult patients of ages 18 to 65 years with a confirmed diagnosis of type 1 diabetes or type 2 diabetes based on the current ADA guidelines. Next. Patients with other forms of diabetes such as cystic fibrosis, pancreatitis were excluded from our study. Also subjects with documented history of dyslipidemia, family history of dyslipidemia, pregnant, prisoners and statin users were excluded. Next. A control group comprises of healthy adults appearing for routine medical evaluation. Next. So statistical analysis, coming to that. So we used factor analysis. So factor analysis involves condensing various related factors, which in our study are 7 individual lipid parameters like total cholesterol, LDL, SDL, TZ, non-SDL, TC-SDL ratio, TZ-SDL, and these were um, condensed to two unrelated factors, which are also called orthogonal factors, to quantify the degree of CVD risk. And for this, Varimax rotation method was used. The two orthogonal factors are factor 1, named as TC-SDL, which includes non-SDL cholesterol, LDL, TC-SDL ratio, and factor 2 is named as SDL-TZ, which includes TZ, SDL, TZ, SDL ratio. We'll discuss in detail about this in subsequent slides. Next. So we used a Cepheid method for pairwise comparison in median values of lipid parameters. Ordinary least square regression models were used to determine linear trend of mean lipid composite scores across study groups after adjusting confounding factors like age, sex, race, and BMI. Two-dimensional scale was used to trace the change in means of composite scores across study groups. We'll talk about this more in subsequent slides. Next. So coming to results. Next. This is the table 1 for comparing anthropometric, biochemical, and therapeutic parameters. This looks busy, so we have splitted this into two parts. The first part, here, as you can see, there were no significant differences in height distribution between study groups. And also subjects with type 2 diabetes who were older, heavier, and had higher systolic and diastolic blood pressure. The non-remitters had significantly higher fasting glucose levels. We'll talk about the lipid parameters in following slides. Next. Here, as you can see, the total daily dose of insulin was similar among 3 groups at the time of diagnosis, but significantly higher in non-remitters at 6 months and at 12 months. There were no significant differences in gender distribution between study groups. And lastly, more white subjects were represented in remitters in comparison to other groups. Next. So the comparison of patterns of glycemic control in groups. At the diagnosis, A1C was significantly higher in remitters and non-remitters compared to type 2 diabetes. However, at 6 months, the A1C was significantly higher in non-remitters compared to remitters and type 2 diabetes, and similar pattern at 12 months. Next. This is the box plot on non-SDL. So a box plot represents 50th percent interquartile range while X represents the mean. Here non-SDL was significantly lower in controls in comparison to type 2 diabetes subjects, non-remitters, but was similar to remitters. Additionally, non-SDL was significantly lower in non-remitters compared to subjects with type 2 diabetes, but similar between remitters and non-remitters. Next. This is the plot on triglyceride. Serum TG concentration was significantly lower in controls compared to subjects with type 2 diabetes, but was similar between remitters and non-remitters. However, while TG was similar between non-remitters and subjects with type 2 diabetes, it was significantly lower in remitters compared to subjects with type 2 diabetes. This is the box plot on TZ-SDL ratio, where you can see that the ratio was significantly different among the 4 groups. The study showed that the ratio was significantly lower in controls compared to subjects with type 2 diabetes, non-remitters, but is similar to remitters. Also, the ratio was significantly lower in remitters compared to non-remitters. Next. Uh, this is the box plot on total cholesterol SDL ratio. The ratio was significantly lower in controls compared to the subjects with type 2 diabetes, the non-remitters, but was similar to remitters. Additionally, the ratio was also found significantly lower in remitters compared to non-remitters. So Dr.
So,
continue.
yeah. So table 2 shows the result of factor analysis of the lipid parameters. So what we've tried to do here is to actually simplify what Sadi has shown in the past previous maybe 6-7 slides. And so we use this thing called factor analysis, which is a way of taking all those 7 variables and then condensing them into 2 factors that actually have 90% ability to account for the variances in the original parameters. So the first 4 columns, will be different from the last 3 columns, I would say. But what's more important is the commonality, which is the correlation between those factors when assessed with the previous 7 parameters. And the correlation is really high, around 90%. So let's look at factor 1. So what this shows is a linear increase in the mean composite scores going from the controls to the remitters, non-remitters, and type 2 diabetic patients, showing that as you move from the control group all the way to type 2, there's a linear increase in the risk for CVD. And then we looked at factor 2 as well, which is HDL-TG. I'm simplifying my presentation, but this HDL-TG doesn't mean HDL times triglyceride. It's much more than that. You have to extract these factors and then rotate them through the confounders using what's called Varimax rotation, and then give them a composite score before you can then apply them to the analysis. So here you can as well see that.
Yeah. Oh, sorry.
Okay. So you can also see another linear increase in the mean composite scores ranging from the control groups to the remitters, non-remitters, and type 2 patients. But let's show you this in a 2-dimensional output. So this is a 2-dimensional depiction of the mean composite scores. So using our factor 1 and our factor 2 to see which groups are in the high risk quadrants and which groups are in the low risk quadrants. So you can see that the controls and the remitters are in the lower risk or low risk quadrant basically, whereas the non-remitters and the type 2s are in the higher risk quadrant for cardiovascular disease. Krish.
Okay, hi everyone. So just moving on to the discussion section now. So the whole point of our study was to characterize these early lipid phenotypes in adult population that had type 1 diabetes stratified by remitters, non-remitters, type 2, and also compared to the controls. What we're hoping to do is confirm the prior studies that were done in the pediatric population, which we already went through, and hopes of having similar results. So go to the next slide. So what we detected was there is this dichotomy in the earliest post-diagnostic lipid-based CVD risk profile in type 1 diabetes. And this is specifically what we found is that the non-remitters demonstrated a similar lipid phenotype as subjects with type 2, which is also found in the pediatric study, while the remitters showed a more favorable lipid profile similar to the controls. Right. So and then the next part that we wanted to make is that using the factorial statistics adjusted for different confounders, we showed that both the controls and the remitters occupy the low risk quadrant in the 2-dimensional composite risk model, whereas the non-remitters and subjects with type 2 occupy this higher risk quadrant for lipid phenotypes. So then the question becomes, what's at play here? And, insulin resistance is an important thing to consider. And, this table here is extrapolated from the table 1, which we had already shown you. So on the left-hand panel, for each group there, you're going to see the actual value, and on the right is the standard deviation. And at baseline, the total daily dose of insulin was similar, whereas over time, you can see how much more of an increase there was in the non-remitter group. And so, some part of this does make sense that they have less, C-peptide production, they're going to need more insulin, but, there is also a pattern of worsening insulin resistance here because the A1Cs did get progressively worse as well. So, a further explanation of glycemic control during the study did show this pattern. And it's like trying to explain that, suggesting that the efficient endogenous C-peptide production after the diagnosis of type 1 diabetes, which is present in remitters, is necessary to maintain some sort of optimal glycemic control as well as lipid profiles. So what about C-peptide? So we previously suggested that the mechanism of early dyslipidemia in non-remitters is the absence of C-peptide mediated protection of lipid during puberty, which is denoted by this graph here, which we previously showed from the 2019 study. And this is consistent with some sort of protective role of C-peptide on the vasculature, which was also seen on subgroup studies in the DCC trial. So how does C-peptide play a role here? It's a 31 amino acid peptide. It's co-secreted with insulin and has a longer half-life of 31 minutes compared to insulin, which is only 4 minutes. Makes it a more valuable tool to measure. And it was isolated back in the 1960s. There's been various developments in how it's being measured over time. But as far as we know, there's no known receptor. And what we're thinking is that there's some downstream regulatory systems that involve the cell proliferation, apoptosis, and other inflammatory signals through NF-kappa B and TNF-alpha, which kind of mediate some sort of protective mechanism in the vasculature. And it's been related to, a lower incidence of neuropathy, retinopathy, and nephropathy. So we're just, trying to fixate on whether there is a relationship between C-peptide having a protective role. And the next slide, we could see that, there's different organ systems which are involved with C-peptide mechanism. And this vascular protective effect of the C-peptide and those with residual beta cell function has been reported, and it may be an indirect explanation for the lower prevalence of these complications that we see later in life. And C-peptide itself, because of these effects, has been used in the past to help understand whether there is any role as exogenous administration. And going on to this slide now, so the 2018 study had concluded that partial clinical remission was associated with lower likelihood of early dyslipidemia in type 1 diabetes, like regardless of glycemic control. And as you can see here, at 6 months, there was a significant difference in the A1C and total daily dose of insulin. And that gap was pretty much neutralized by 4.5 years. So we're saying that, regardless of the glycemic control and degree of adiposity, which was not shown in this graph here, there's something else at play, which may actually be C-peptide in this mechanism of insulin resistance. So what is the possible mechanism model that we're suggesting here? So you can see in this graph on the left, for type 2 diabetes, where there's a functional absence of endogenous C-peptide. It's available but not working. In non-remitters, there's undetectable C-peptide; they just don't have it around. But there may be an active role of C-peptide in those remitter groups, and then this kind of threefold play is kind of putting at some emphasis on the pathophysiology of what's going on, which has a direct association with the dyslipidemia that we're seeing in this patient population. So what are the strengths of our study? We had a rigorous definition of the partial clinical remission, as we previously defined as the insulin dose-adjusted A1C. We're able to extract a good amount of longitudinal data, glycemic control, demonstrate the impact of the PR on glycemic control as well. And luckily, we had a great statistician working with us, and we were able to use this factor analysis to help kind of mediate some of the variability and things like that that are going to be at play when you have so many different lipid parameters involved to help estimate ASCVD risk. And we also were able to include a control group for comparison. You can see in the graphs were previously done, there was a definite trend. So there are also some notable limitations to the study. It is a retrospective design, so we can't make any causality associations here. And unfortunately, for a lot of these blood draws, we could not confirm fasting state for the lipid data. However, we did use parameters in there such as non-HDL, which are independent of fed state. The type 2 diabetes cohort, as Sadie had mentioned, was heavier and were older, but we did adjust for these other confounders during the analysis. And there's, in the adult population, it makes it a little bit more complicated as compared to pediatrics. There's so many other factors that can affect lipid levels, such as smoking, alcohol use, exercise activity, thyroid dysfunction, and other medications such as antivirals, antipsychotropics, and we didn't necessarily include all these in the analysis. We excluded everybody that was on a statin during the period of the data that we collected, but we didn't look into other types of lipid-lowering agents such as fibrates, ezetimibe, and fish oil. However, these are less commonly used in general. And one of the things, the statistical analysis didn't prove to be significant enough for measuring the C-peptide and then doing analysis on that. So that would have been good to have as well. So our conclusions, so we detected this dichotomy in the earliest post-diagnostic lipid-based CVD risk profile type 1 diabetes, where the non-remitters are similar to type 2 diabetes, and the remitters are similar to the controls. And we made use of this factor analysis to help us kind of quantify risk groups, and it was consistent with what was found in the prior studies. Okay.
So flashback to 2019, this was one of the slides we presented that year. And the last bullet point here, we had asked this question, whether the partial clinical remission augmented dichotomy in lipids could explain the lower CVD risk in adults who experienced partial clinical remission. And, the study we just presented did show the evidence of the existence of that dichotomy in the earliest post-diagnostic lipid phenotype in adult patients with type 1, which was similar to what we found in children. And it does support the hypothesis that partial remission could reduce or could play a role in the reduction of long-term CVD risk in patients with type 1. More studies will be needed to determine how this phenomenon operates through the lifespan in patients with type 1 and in type 1. All right, so before we round this up, let's go back to this question. In the early stages of pediatric and adult type 1 and type 2 diabetes, this lipidemia is most likely related to which of the following? So we have sex, age, BMI, C-peptide, A1C, and ratio groups. So we think the answer is C-peptide based on our presentation. Special thanks to all these people who have worked on this project at various times over the past 5 years or so. And our statistician, Austin Lee, and Gabriel Jasmine, one of the clinical research assistants, and the members of the adult endocrine group. Thank you for listening.